Hi, my name is Ariana and I'm a student nurse. Today I will be talking about reactive arthritis and psoriatic arthritis belonging to the spondyloarthritis group. So I hope you learned something.
Reactive arthritis is an inflammatory arthritis which manifests after several days to weeks after a gastrointestinal or genitourinary infection. It is also described as a classic triad of arthritis, urethritis, and conjunctivitis. This is the triad of reactive arthritis. First is urethritis, which is cant P, which is the inflammation of the urethra, with the most common symptom being painful or difficult urination. Next is conjunctivitis, which is cant C, inflammation of the outer membrane of the eyeball and the inner lid or eyelid. And lastly is the arthritis, which is can't climb a tree. So the three components is can't P, can't see, and can't climb a tree. However, a majority of patients do not present with the classic triad. It was previously called Reiter syndrome, named after Hans Reiter, who first described this syndrome. The name Reiter syndrome was dismissed because it is believed that Hans Reiter was a member of the National Socialist German Workers' Party, or famously known as the Nazis, and the director of the Kaiser Wilhelm Institute of Experimental Therapy, under whose leadership the war prisoners were subject to many inhumane experiments. Today, it is believed that this disorder is due to an aberrant autoimmune response to the gastrointestinal infection caused by Salmonella, Shigella, Campylobacter, or Chlamydia. Etiology of reactive arthritis. Reactive arthritis is known to be triggered by a bacterial infection, particularly of the genitourinary, which you have here, and the gastrointestinal tract. Genetics may be a factor in whether or not a patient has developed reactive arthritis. According to research, people who have the gene HLA-B27 are more likely to develop reactive arthritis. However, not everyone with the HLA-B27 gene will develop reactive arthritis if they get an infection, which triggers the immune system to create antibodies. That's where immune response happens. And after that, the antibodies cross over and attack normal body cells, then which causes inflammation that affects the joints, which then results through reactive arthritis. So for better understanding, I've made this very simple illustration. So I'm going to tell you the legend of these shapes. So the triangle represents the antigens like bacteria, virus. The red arrows represents the antibodies that attacks the antigens. Since our immune system's job is to kill these things. This broken line over here represents passage of time. So of course, our body again has normal tissues, which we have here representing the violet circle, which is our body's normal tissues. What happens here is the ones who these red arrows, which is the antibodies for this specific antigens, cross over and attacks these normal body cells. That's why it is called reactive arthritis, since it reacts to the infection that the body already went through. And after that, it causes inflammation that affects the joints. So that's it for the pathophysiology. Here are the clinical manifestations of reactive arthritis. First is arthritis, which appears 2 to 4 weeks after the initiating event. This is asymmetric, which is one side is affected more than the other. This is more common in the knees, ankles, and small joints of the feet, hence the term can't walk. Next is sausage digits or dactylitis, as referred here in the picture. Pain on range of motion. Enthesopathies in the Achilles tendon. And sacroiliitis, which is low back pain. The clinical manifestations of the eye includes conjunctivitis, iritis, uveitis, episcleritis, and corneal ulceration. Next, we have the genitourinary, which is the urethritis. Skin and nails, which includes writer's nails, which is thickened and opacified, crumbling, and non-pitting. Keratoderma dendrographia, hypertrophic skin lesions on palms and soles of the feet. Other clinical manifestations include weight loss, fever, and amyloidosis. Complications of reactive arthritis includes recurrent arthritis, which is 15 to 50%, chronic arthritis or sacroiliitis, ankylosing spondylitis, urethral stricture, aortic root necrosis, cataracts, cystoid macular edema. Next are the diagnostic and laboratory procedures. Blood test. The doctor might recommend a sample of blood to be tested for evidence of past or current infection, signs of inflammation, antibodies associated with other types of arthritis, a genetic marker linked to reactive arthritis. Next is joint fluid test. The doctor might use a needle to withdraw a sample of fluid from within an affected joint. This fluid will be tested for white blood cell count. An increased number of white blood cells might indicate inflammation or an infection. Another is infections. Bacteria in the joint fluid might indicate septic arthritis, which can result in severe joint damage. And then crystals. Uric acid crystals in the joint fluid might indicate gout. This very painful type of arthritis often affects the big toe. Lastly is the imaging test. X-rays of the lower back, pelvis, and joints can indicate whether the patient have any characteristic signs of reactive arthritis. X-rays can also rule out other types of arthritis. Treatment modalities. The goal of therapy in reactive arthritis is to provide symptomatic relief and prevent chronic complications. If an infectious agent has been identified as a trigger for reactive arthritis, antimicrobial therapy is strongly recommended, often for a long term of 3 to 6 months. For medical management of reactive arthritis, if the reactive arthritis was triggered by a bacterial infection, the doctor might prescribe an antibiotic if there is evidence of persistent infection. So here are the medications that includes in treating reactive arthritis. First is nonsteroidal anti-inflammatory drugs, or NSAIDs. This can relieve the inflammation and pain of reactive arthritis. Next is corticosteroids. Injection of a corticosteroid into affected joints can reduce inflammation and allow the patient to return to their normal activity level. Next is topical steroids. This might be used for skin rashes caused by reactive arthritis. Lastly is rheumatoid arthritis drugs. Limited evidence suggests that medications such as sulfasalazine, methotrexate, can relieve pain and stiffness for some people with reactive arthritis. Physical therapy. All patients should be urged to become physically active. Strength and exercises are a key component of a long-term therapy to prevent muscle wasting. A physical therapist can provide with targeted exercises for the joints and muscles. Strengthening exercises develop the muscles around the affected joints, which increase the joint support. Range of motion exercises can increase the joint's flexibility and reduce stiffness. Here are the nursing diagnosis and its corresponding nursing management for reactive arthritis. First is impaired physical mobility related to painful joint. Here are its nursing management. Provide assistance with activities of daily living. Promote bed rest. Promote and facilitate ambulation when possible. Aid with each initial change, like dangling legs, sitting in chair, ambulation. These movements keep the patient as functionally working as possible. Early mobility increases self-esteem about reacquiring independence and reduces the chance that debilitation will transpire. Execute passive or active assistive ROM exercises to all extremities. Exercise enhances increased venous return, prevents stiffness, and maintains muscle strength and stamina. It also avoids contracture deformation, which can build up quickly and could hinder prosthesis usage. The next nursing diagnosis is ineffective coping related to pain and discomfort. Provide an opportunity for the patient to discuss concerns about reactive arthritis and its effect on lifestyle. Next is assist patients set realistic goals and identify personal skills and knowledge. Involving patients in decision making helps them move toward independence. Next is to provide chances to express concerns, fears, feeling, and expectations. Verbalization of actual or perceived threats can help reduce anxiety and open doors for ongoing communication. Lastly, convey feelings of acceptance and understanding. Avoid false reassurances. An honest relationship facilitates problem solving and successful coping. False reassurances are never helpful to the patient and only may serve to relieve the discomfort of the care provider. Prognosis. The progression of reactive arthritis is variable, but in most people, the disorder is self-limited with the resolution of the symptoms occurring by 6 to 18 months. Mortality is very rare today and is usually due to the treatments. In general, causes related to sexually transmitted infections have a worse outcome than those caused by gastrointestinal infections. Despite a cure, recurrences are known to occur in 25 to 50% of cases, especially those who are HLA-B27 positive. Reactivation may signal a new infection or stress. About 20% of patients will have a long-term disease that results in enthesitis and destructive arthritis. Elevation of ESR, lack of response to NSAIDs, and involvement of the hip joint usually is indicative of poor outcome. Psoriatic arthritis is an inflammatory arthritis associated with psoriasis. It can vary in severity. The patient might have a mild stiffening and soreness in the joints, or it could be completely destroyed in a condition called arthritis mutilans. It occurs in about 10 to 20% of patients with psoriasis, a skin condition which causes rashes and scaly patches to occur in places like the elbows or the scalp. Usually, it occurs within 10 years of skin changes. It typically affects people of middle age between 30 to 50. It is part of the group of conditions called seronegative spondyloarthropathy. These are seronegative inflammatory arthritis, like reactive arthritis, ankylosing spondylitis, and enteropathic arthritis. Here are the recognized patterns of psoriatic arthritis. Symmetrical polyarthritis presents similarly to rheumatoid and is more common in women, and this affects the hands, wrist, ankles, and the distal interphalangeal joints of the fingers. The MCP joints of the knuckles are less commonly affected, unlike rheumatoid arthritis. Asymmetrical polyarthritis. This is where it only affects a few joints, and this pattern typically affects the digits of the fingers and the toes, and also the joints of the feet. Spondylitic pattern, which is most common in men. It presents with back stiffness, sacroiliitis, and atlantoaxial joint involvement at the top of the neck. Other areas that could be affected are the spine, Achilles tendon, and the plantar fascia. The etiology of psoriatic arthritis. First is psoriasis. Having psoriasis is the single greatest risk factor for developing psoriatic arthritis. People who have pitted, deformed nails are especially likely to develop psoriatic arthritis. Next is age. Although anyone can develop psoriatic arthritis, it occurs most often in adults between the ages of 30 and 50. Genetics. Psoriatic arthritis runs in families. Genes only set the stage for psoriatic arthritis. About 40% of people with this condition have a brother, sister, parent, or other family member who has psoriasis or arthritis. Next is infections. Some people get psoriatic arthritis after an infection, but it's not clear which bacteria or viruses are to blame. The strep bacteria that cause sore throats could be one. The HIV virus could also be involved. Psoriatic arthritis is more common in people who are HIV positive. Next is skin injuries. A new plaque sometimes forms on the skin after a cut, scratch, or other injury. The joint closest to the injured area might also swell up. Doctors call this the Koebner phenomenon. Next is stress. Inflammation is also part of the body's response to stress. Being under constant tension releases a barrage of stress chemicals in your system. Alcohol. Alcohol promotes joint inflammation. Drinking too much might worsen psoriatic arthritis symptoms. Some people with psoriatic arthritis claim that their symptoms improve when they avoid alcohol. Smoking. Smoking both raises the risk for psoriasis and makes the disease worse. Exactly how cigarettes affect psoriatic arthritis isn't as clear. There is some evidence that people who smoke don't respond as well to their psoriatic arthritis medicine as non-smokers. The pathogenesis of the disease process is hypothesized to start in the skin with an exaggerated immune response to environmental factors and then spreads to the joints in genetically susceptible individuals. The body is triggered to activate the T cells of the immune system, producing inflammatory cytokines and mediators that cause changes and inflammation in the body, which also may result in erosions and joint destruction. In addition to joint damage, this cascade may also damage the ligaments, tendons, skin, and nails. Nail psoriasis occurs in approximately 90% of patients. Clinical manifestations of psoriatic arthritis. For the skin, presence of plaques arises on the skin. Pitting of the nails. These are tiny pinprick-like pits that occur on the fingernails. Onycholysis, which is the separation of the nails to the nail bed. Dactylitis is a classical sign of psoriatic arthritis. This is when you have inflammation on the full finger or full toe. Enthesitis, which is the inflammation of the entheses, which are the points at which tendons insert to bones, which gets inflamed. Here are a few other associations in psoriatic arthritis. First is eye disease, which includes conjunctivitis and anterior uveitis. Next is aortitis, which is the inflammation of the aorta. And last is amyloidosis, in which you have amyloid deposits throughout the body. For the diagnostic and lab procedures for psoriatic arthritis. For the imaging test, we have first X-rays. X-rays can help pinpoint changes in the joints that occur in psoriatic arthritis but not in other arthritic conditions. Magnetic resonance imaging, or MRI, which uses radio waves and a strong magnetic field to produce very detailed images of both hard and soft tissues in your body. This type of imaging test may be used to check for problems with the tendons and ligaments in your feet and lower back. For the laboratory procedures, we have rheumatoid factor. RF is an antibody that's often present in the blood of people with rheumatoid arthritis, but it's not usually in the blood of people with psoriatic arthritis. For that reason, this test can help the doctor distinguish between the two conditions. Next is joint fluid test. Using a needle, the doctor can remove a small sample of fluid from one of the affected joints, which is often the knee. Uric acid crystals in the joint fluid may indicate that there is gout rather than psoriatic arthritis. The treatment modalities of psoriatic arthritis. Treatment should be guided by disease severity, degree of joint damage, the extent of extra-articular disease, patient preference, and other comorbidities. Non-pharmacological therapies, including physical therapy, occupation therapy, exercise program, and smoking cessation, should be strongly encouraged and incorporated in the treatment plan. Treat-to-target approach is the most effective way to control disease activity and minimize joint damage. A target of low remission or low disease activity should be employed depending on disease extent, chronicity, and other comorbidities. For the pharmacological therapy of psoriatic arthritis, first we have NSAIDs, or non-steroidal anti-inflammatory drugs, which can relieve pain and reduce inflammation. Over-the-counter NSAIDs includes ibuprofen and naproxen sodium. Next is disease-modifying anti-rheumatic drugs. These drugs can slow the progression of psoriatic arthritis and save the joints and other tissues from permanent damage. Next is immunosuppressant. These medications act to tame your immune system, which is out of control in psoriatic arthritis. These medications can increase your susceptibility to infection. Next is biologic agents, also known as biologic response modifiers. These medications target specific parts of the immune system that trigger inflammation and lead to joint damage. Lastly, we have newer oral medication, which decreases the activity of an enzyme in the body that controls the activity of inflammation within the cells. Potential side effects include diarrhea, nausea, and headaches. Here are the nursing diagnosis and its corresponding nursing management for psoriatic arthritis. First is chronic pain related to joint inflammation. The nursing management are: administer prescribed drugs, educate patient of pain management approach that has been ordered including therapies, medication administration, side effects, and complications. One of the most important steps toward improved control of pain is a better patient understanding of the nature of pain, its treatment, and the role patient needs to play in pain control. Implement non-pharmacological interventions when pain is relatively well controlled with pharmacological interventions. Non-pharmacological interventions should be used to reinforce, not replace, pharmacological interventions. Lastly, refer the patient to a physical therapist for assessment and evaluation. This is helpful to promote muscle strength and joint mobility, and therapies to promote relaxation of tense muscles. The physical therapist can help the patient with exercises suitable for his or her condition. The next nursing diagnosis is ineffective therapeutic regimen management, and its corresponding nursing managements are: tell the patient about the advantages of adhering to the prescribed regimen. Patients who understand the effectiveness of the suggested treatment to reduce risk or to promote health are more likely to engage in it. Next is coordinate the therapy to the patient's lifestyle. This approach promotes compliance. A one-size-fits-all is usually ineffective. Next is involve significant others in explanations and teaching. Encourage their support and assistance in following plans. Involving significant others promotes support and assistance in strengthening appropriate behaviors and promoting lifestyle modification. Prognosis of psoriatic arthritis. This is considered to be an aggressive disease with the potential for significant morbidity and poor quality of life in patients. Some features are considered to be harbingers of a severe disease course and poor prognosis. These include a large number of actively inflamed joints or polyarticular presentation, elevated ESR, clinical or radiographic damage, loss of function, and diminished quality of life.
That's it for both topics. I hope you learned something. Once again, this is Ariana. Thank you for listening and have a good day.